Patient cases are shared in this session for educational purposes. In some cases, the information does not relate to an individual and instead represents a compilation of disease presentation. In cases involving individual patient information, the patients have authorized the discussion of their case in the setting.
I'm going to go ahead and get started. Good afternoon, everyone, and welcome to our second series in the Long COVID and Post-Viral Syndrome ECHO with the University of Utah and Bateman Horne Center. I'm Talia Reschioni, the Education Director at the Bateman Horne Center, and I run these sessions with ECHO Manager Sarah Day. Today, we will be hearing from pulmonary critical care doctor Jeanette Brown, who is also an associate professor and the medical director of the Comprehensive COVID Clinic at the University of Utah. Okay, Dr. Brown, I'll turn the time over to you.
Awesome. Thank you so much for joining, guys. This is meant to be interactive. Love if you guys have questions, pop them in the chat, tell you if you want to keep track of that, or if people just want to pipe up. The whole goal of this is that we're all sort of learning as we go. Love to hear what people's experiences are, good, bad, in between. So long COVID and supplements, I feel like this has been something we've gotten a ton of questions about. And, it's an evolving field too. And so I was just curious looking in what data there is or isn't, but also what patients are asking about. So please pipe up. So long COVID and supplements, here we go. And so I have no disclosures. I'm in academic medicine. I don't have any money. I'm kidding. I have no relationship with any supplement or pharmaceutical companies. I don't have any conflicts of interest with this stuff. So I'm going to kind of give you good, bad, and everything in between. The goals of this presentation is to make people aware of all the over-the-counter supplements that patients are taking for long COVID potentially. I focus this primarily on supplements and things like that. I've stayed away from sort of off-label use of like FDA-cleared medications, but, discuss the potential benefits and harms and review any monitoring for side effects if known about these particular items. And my thing is you don't know what you don't know. When I chat with patients that come into my clinic, we ask about medications often, but it's important to ask about supplements that the patient is taking. And those can include vitamins, minerals, plant and animal extracts, hormones, and amino acids. Different formulations exist. They can be liquids, powders, teas, nutraceuticals, and essential oils. And fun fact, in the US, 4 out of 5 adults report having taken at least one of these. So they're really common. There's a very large, financial interest in a lot of these too, because there's a lot of money. But there's also some monitoring and health aspects as well. And this is very US centric for my non-US based audience members. The FDA generally does not approve dietary supplements, claims, or labeling before use. And under the FD&C Act, a firm is responsible for ensuring that the dietary supplement a manufacturers distribute is not adulterated, misbranded, or otherwise in violation of federal law. This is from the FDA website. The challenging part of this, though, is that this is something we sort of get, can be more of an issue later after something bad has happened. There's no pre-monitoring. So if you go to the drugstore and you pull an aspirin off the shelf, it's either going to have 81 milligrams or 325. It can't have more, can't have less, can't have other stuff in it. Supplements are not regulated in some way. And so it's a little bit on the consumer patient to know what they're getting in theory. And that's where we get into, it's really the Wild West, as I sit here in Utah. There are hundreds of dietary supplements on the market that have contained undeclared or banned pharmaceutical ingredients, including those that were subject of FDA warnings. There was recently a quote, alkalinized water that was actually made in Las Vegas area that they ran it through some sort of processing device that basically inputted a chemical found in jet fuel that actually caused the death of one woman. One patient needed a liver transplant and an infant was hospitalized based on. And they are the subject of a $300 million lawsuit right now. They're probably actually on the hook for even more than that. So the problem is you just don't know because of the regulations for these things. It's like you just don't know. And many products marketed for weight loss, muscle building, or other things have contained illegal substances, and they're marketed usually among young adults who use them more frequently. So how do you find things that are good quality? There's the USP. That's a verification program that helps to protect consumers. That being said, it's not government regulated, but it's been used by a number of countries to basically look at manufacturing standards, and that they won't contain, contaminants, toxic botanical species, or greater amounts of active or compounds that are indicated on the label. And this has been around for a while, since actually the 1820s, and is the only one that sets standards and is recognized by US federal law that offers this sort of third-party validation. The other fun fact, I did this the other day, just a morbid curiosity. I don't know how you guys feel, but it sometimes can be incredibly overwhelming to try to keep track of everything. I just pumped in the term COVID into PubMed, and there were 400,000 results for a condition that the earliest reports of this were in 2019. So it can be really, one of the biggest challenges I find is trying to keep up with information. And then the other thing is how do you find good information? So PubMed, if you type in COVID and supplements, will give you 3,000 results, which is a little bit more palatable, but still, at least in theory, these are going to be peer reviewed. But if you pop it into Google, you get a ridiculous amount of results, 102 million results in 51 seconds. So I don't know about you, but this has been something that sort of, I feel like, is an ongoing challenge, that you have to keep up with the information out there. And the challenge with the internet is anybody can put anything on the internet. The other disclaimer I'm going to give you about the information I'm going to give is little is known about pregnancy or breastfeeding with a number of these supplements. And if you have a patient that's concerned about becoming pregnant, is pregnant, or breastfeeding, I would defer to somebody in maternal fetal medicine or OB-GYN for specific information, just because, even in regular medicine with a lot of medications, they're pregnancy category C, aka we don't know. And the other consideration, again, with patients is allergies to specific ingredients or foods is something you got to keep in mind. And if a patient is going to use supplements, I encourage them to sort of keep a symptom diary as well, and not to make a lot of changes with lots of different things, because then that can be super confusing as to figuring out what's useful or what's not. And any compound, be it over-the-counter supplement or medication, can cause drug-induced liver injury. And I've seen that in my career in the ICU. So again, it's important to monitor patients when they're taking new medications, period, but also to know about what supplements they're taking. So common things being common, I see a lot sort of with our fatigue workup, looking at B vitamins and folic acid, which is B9, vitamin D and iron, as common things we sort of look at initially when somebody comes in with a common complaint of fatigue, which we see a lot of with long COVID. It's also important to get a good history again, chatting to people about their diet. I personally am a vegetarian, but talking to folks who have more restrictive diets, potentially like vegans, or folks that are doing a lot of elimination diets with a concern of like mast cell activation or some of the other things that we see, because there have definitely been times we've seen scurvy. So just be super, super careful with this. I'll talk more about these vitamins in a bit, but the other thing also to keep in mind, because a lot of our patients who are impacted by long COVID are female patients who could be in the childbearing years. And it's important to know about folic acid supplementation for neural tube development. And so again, just depending on what your patient's overall conditions are, important to know about those things. B vitamin supplementation, I laugh because if most people know me, I usually have an energy drink in my hand because, ICU careers tend to keep one very busy. And I actually was looking at the side of my can. This is not an ad for Monster. But like there's actually B3, B6, B12, and B5 in this. So there's a lot of things we eat and drink that have a lot of actual supplementation, but you can directly measure B vitamins. And again, depending on what things you're actually getting, you may get a lot of extra B vitamins. Generally, these don't really get into the toxic range, but if you are B12 deficient, you can see anemia associated with this, and that can be a reasonable, reason why people are fatigued. And then fat soluble vitamins, these are the ones though that get my attention because these ones are stored in our fat, which means that if you overdose on them, in contrast to like vitamin B and C, these actually will accumulate and cause toxicity. And so A, E, D, and K were always the ones that I learned about. Overdosing on vitamin A is actually known to be teratogenic. So you can actually get congenital abnormalities in babies that are forming, but it also can lead to alopecia, hair loss, ataxia, hyperlipidemia, and liver toxicity directly. There was recently a case of vitamin D toxicity, D as in dog. The patient actually was this was actually in the UK, was taking a bunch of supplements and did not realize there were extra D supplement in multiple compounds. And that can give you GI symptoms. It can lead to elevated calcium. And back in medical school, I always remembered, with hypercalcemia, calcium calms. And so they get a lot of muscle fatigue. It actually can cause direct cardiac abnormality, kidney damage, hypertension, and bone demineralization. And this particular patient died of multi-organ failure, which was very sad, both liver and heart toxicity. Vitamin E supplementation can get you into trouble with increased bleeding risk, possible increased cancer risk. And when they've done large population studies, actually saw increased all-cause mortality. D got a lot of extra hype and interest during COVID, partially because in my world, vitamin D deficiency at baseline, it leads to worse outcomes in the ICU. But supplementing while patients are sick in the ICU actually doesn't appear to make a big difference. And then vitamin K, there's a lot more limited data on this, but has the potential to lead to abnormal bleeding and clotting. So my sort of takeaway from looking at this, there's actually a really nice chart and up to date if you have questions about what the current RDA doses are. But if a patient is going to supplement beyond current RDA doses for these, I would actually recommend directly measuring these levels as to not get into trouble. And then this gets into the D one, which is, very popular. I remember when I was a resident in Michigan as a general medicine resident, my outpatients, we'd measure vitamin D, and like I was shocked if anybody had a normal vitamin D level, because a lot of this comes from diet and sun exposure. And if you have dark skin, your melanin in your skin will actually block vitamin D absorption. So, and again, deficiency is associated with lots of worse disease outcomes. And then there was that case of, unfortunately, overdose. They say toxicity at that level is somewhere around 60,000 international units per day, but there's not a ton of data on that, and we'd be very careful. The current recommended daily allowance is 4,000 international units a day. And there's actually two flavors of vitamin D that you can get. One is D2. And if you get the prescription form of D2, it's the 50,000 units per week, and it's a vegetarian source. And D3, on the other hand, is usually fish derived, and it's made in our skin. That's actually the form that we make on our own. And if you supplement with D3 versus D2, D3 tends to raise people's levels more than D2. There is some data potentially suggesting it's harder to get toxic with D3 versus D2 supplementation. And it gets into absorption, how much is fat containing in your diet. And then also there may be some impact based on the patient's body mass index. But again, if you're going to supplement, it's probably a good idea to repeat measurement between 3 to 4 months after supplementation to avoid toxicity. iron, there's actually been a lot of this talk recently in general. There was a new report that actually came out in JAMA looking at iron deficiency. And iron is actually, most of us know it's important for red blood cell production, but it turns out it actually does more than that. It actually is important in making neurotransmitters, including serotonin. And people who have deficiency may actually have more tendency to have things like depression and fatigue as well. And high rates of deficiency in young women, that JAMA report estimated about 40% of women, teens to young women, are deficient. And then this gets into what's your optimal target for iron, also known as and ferritin levels. And like here, our current lab like deficiency level is set at 13, which is probably actually too low. And ideally wanting to target anywhere between 25 to 50 with newer research, but your lab values may show different. And then you also have to remember that ferritin itself, though, is an acute phase reactant. So we don't typically measure ferritin while somebody's in the hospital because it will be increased, but doesn't really reflect more of their iron stores. Specifically looking at long COVID, were some very interesting findings with a study called Iron Man, which I will give the cardiologists. They have the best study names, I think, out of all the different areas, but these were accidental findings. And because this study was actually looking at iron supplementation and iron deficiency in people with heart failure, the middle of COVID threw that off. And what they did was they kept tracking those patients, and they found that patients that did not have iron deficiency, so they had adequate iron stores, were less likely to develop severe effects from COVID. And this data was also validated by patients with thalassemia, which tend to have higher levels of circulating iron. And those patients actually did better with COVID as well. So supporting, the complex regulation of iron in infection is, well known, but needs to be studied further. But iron deficiency looks bad. There's also some new data this year from Nature Immunology out of Cambridge looking at iron dysregulation and inflammatory stress. And they found in people with long COVID, more of these, though, were hospitalized than not. But they found a lot of inflammation, low serum iron, and altered iron homeostasis and iron dysregulation. The authors, though, the caution that it's not just as simple as, hey, you just need to, everybody should get iron supplementation. The recommendation, sort of based on this prelim evaluation, was to, if someone's deficient in iron, you should replace it. But that iron dysregulation may be part of the pathogenesis of long COVID. And its deficiency was also associated with increased levels of inflammatory markers such as IL-6 and CRP. And low levels of iron could theoretically impair the efficacy of vaccination, which is interesting as well, because they're trying to protect people from getting long COVID. And again, with older patients, you really want to monitor iron levels. And then iron supplementation has changed. When I did my internal medicine training, like 10-ish plus years ago now, we used to give people iron tablets like 2 or 3 times a day, and that was miserable. And it actually turns out it's not very effective. So if you give people too much iron, it's just like you have hemochromatosis. Your body will shut down those receptors and you'll get more GI intolerance of the iron supplementation. So the current recommendations are 325 ferrous sulfate tablet every other day on an empty stomach. If patient can't handle it on an empty stomach, you can take it with food, but it may block absorption. And this dosing is effective. It was done in head-to-head studies with daily and even more than that. And actually, people tolerated this dosing better, but it can take up to 6 to 12 months for full iron stores to be repleted. The other fun fact is that compounds found in tea and coffee can actually block iron absorption. There have been interesting case reports, primarily in Asian women who drink a lot of tea, but severe iron deficiency because the compounds, the tannins, actually block absorption of iron. And so being that just iron deficiency is common in our population, common in women, it's important to look at. And then if you're going to dose for supplementation for iron, you can follow ferritin levels like every 6 to 12 months. Other fun things you will see are amino acids. Branched chain amino acids, BCAAs, you'll see a lot. Leucine, isoleucine, and valine are essential amino acids with well-established effects on protein synthesis and glucose homeostasis. They're important in our lymphocyte proliferation for our immune system, protein synthesis, and mitochondrial function. They also may have a role in gut mucosal defense, which is kind of interesting. And often you see a lot of these in what I refer to as bro science as workout supplements. You see a lot of these sold in powder form. That being said, there's no free lunch and everything can have potential issues. Some patients will report nausea, diarrhea. Some people will report mood issues, fatigue, which is ironic because we're using this often to help with fatigue, and potential increased risk of cardiovascular disease. But it's relatively safe, at least from the prelim data, in doses of 12 grams per day or less. This is also one that I've seen less of information about, which is beta-hydroxy beta-methylbutyrate, which is a mouthful, and referred to as HMB. It's actually an active metabolite of leucine. Modulates several processes, including protein metabolism, insulin activity, skeletal muscle hypertrophy, cell death, apoptosis, and muscle stem cell proliferation and differentiation. When they've used these for supplements, it's usually 3 grams per day. And they did a study that in older adults that found it prevents the decline of muscle mass and preserves muscle function in folks who had hospitalization and after recovery. There was also some data that looked at short-term anti-inflammatory and anti-catabolic or muscle breakdown effects and improved pulmonary function actually in COPD in the ICU as well. So this is another area that people are starting to have interest in. These are just supplements you can get from GNC and other places. But again, just be really careful when people are getting these, try to get from reputable places. This is another interesting one, selenium. It's an essential nutrient for us. It is actually the second highest mineral found in the human body after iron. And it's involved in a lot of important processes, including neurologic, endocrine, cardiovascular, and immune functions, along with it has an antioxidant property. And it's actually been shown to be important specifically for responses to viral infections, especially respiratory viruses. And low concentration of it was correlated with an increased tissue damage and organ failure, prothrombotic activity, clotting, and overall mortality in patients in the intensive care unit, which could explain that correlation with severity in, severe COVID in the ICU. But they also have a potential role for COVID-19 sequelae in long haulers as well. And then there were a number of studies that looked at circulating selenium concentrations were lower in patients with COVID-19 as compared to healthy controls and associated with severity and mortality. And then for supplementation, they recommend the upper limit is going to be 400 micrograms per day. Better uptake with food sources, actually. So food sources, you can look up a list of selenium containing foods. The other thing that's interesting, though, is if you overdose on it, it can give you bad breath, which just sounds bad, but also hair loss, fever, fatigue, and nausea. And what's interesting is if you see a lot of hair supplements, actually, for like regrowing hair, actually there's a lot of selenium in them. So just something to keep track of if someone's like, my hair keeps falling out and I feel bad and all these things, it's important to look at what they're taking. Zinc is also important. You guys may have seen like over the counter, like Zicam and other zinc supplementation. These are essential for maintenance of immune health, cell homeostasis, and reproduction. Deficiency is actually kind of common in the general population associated with immune dysfunction, and it impacts both innate and adaptive immune response. Deficiency is associated with risk of upper and lower respiratory tract infections, and especially in older adults, and is possibly related to anosmia and dysgeusia after COVID infection. And we all remember these from the initial COVID infections. People had a lot of abnormalities in taste and smell. There is some data that suggests zinc gluconate oral suggests it actually will reduce the duration and severity of common cold symptoms. But it is important to be aware that topical zinc nasal swabs, which were sold for a while, I don't know if they're still available, have been associated with sometimes permanent anosmia directly related to it. So if patients want to supplement with it, I recommend it's oral, not topical. And then a prospective randomized control trial, which was called the COVID A to Z study, looked at the efficacy of supplementing with zinc gluconate, ascorbic acid, vitamin C, and in combination to shorten the duration of COVID-19 symptoms. That study was actually failed to demonstrate an improvement in symptoms and actually was stopped due to futility. So, and the reason I point these things out too is because people spend a lot of money on supplementation. And again, you know, with the potential downsides, I think it's important to have sort of a shared decision-making process with your patients and talk about what they're taking and what benefits they might be getting or what downsides they might be having. Magnesium plays a role in modulating innate and adaptive immune system. Subclinical magnesium deficiency has been shown to correlate with low-grade chronic inflammation. And I think this is going to be important for COVID-19 and potentially the persistence of these things. Supplementation, especially in older adults, could help prevent the risk of thromboembolism or clot associated with COVID-19 and other long-term consequences. But this review specifically cites that obviously you need more research to correlate with this. There are two kinds of magnesium supplements on the market. One is magnesium citrate, which is what we do for colonoscopy preps. It has a laxative function. So make sure your patients are grabbing the right one and they're not giving themselves severe diarrhea, not realizing it's from their supplement. Magnesium glycinate, on the other hand, does not have a laxative function. It's hard to overdose magnesium, but the other nice thing is magnesium is easily measured in blood testing. If I have patients in the ICU that are having a lot of ectopy, a lot of PVCs and PACs, I will typically try to target a magnesium level of 2. The other thing is too, if you're struggling to supplement somebody's potassium, if they're deficient in magnesium, that may be why. So if I'm, I'll measure often those two together and depending on what their levels are, appropriately supplement those. Another active area that's very interesting, but not super well understood right now is probiotics. Defined as your live microbes that, when administered in adequate amounts, will confer health benefits. Probiotics primarily have been these bifidobacterium and lactobacilli, can exert relevant immunomodulatory function on the gut axis. And how I've thought about the microbiome is basically we have tons and tons of gut bugs that we live with all the time. And we sort of have a happy relationship with them when it's going well. But if our gut microbiome gets off, it can actually start dissolving the mucus layer that protects our gut cells. And if it really gets out of whack, they will dissolve that layer of mucus, but actually start getting into the gut mucosa itself, the cell layer, and can cause a lot of inflammation there. Specifically with COVID patients, administration of a mix of Lactina planobactis and Pediococcus something strains improved viral clearance, and it reduced both respiratory and gastrointestinal symptoms compared with placebo. The hard part about these, though, is getting the specific combinations and preparations of these that we're using in these studies is a real challenge. But further studies are needed to assess the effects of specific probiotic formulations and combinations and other bioactive compounds that can be given with them on COVID and long COVID symptoms and gut dysfunction with these patients. The one thing I will caution, if you have somebody who has severe immune compromising conditions like active chemotherapy, et cetera, we typically don't recommend probiotics because if their immune function is compromised, you can see systemic dissemination of these bacteria. So this was an interesting review. I have my references at the end, but this one specifically looked at nutraceuticals and dietary supplementation for older adults with long COVID. This was actually an Italian group. And this was kind of interesting that they're looking at sort of long COVID syndrome as a combination of malnutrition, immune dysfunction, low-grade inflammation, sarcopenia, breakdown of muscle, and fatigue. And these are some of their active trials that they're looking at. There's still the Krebs cycle, which I've still memorized 17 times in my training and then promptly dumped. I don't know about you. But then looking at amino acids and supplementation that way, which I talked about a little bit, looking at lactoferrin and probiotics, looking for inflammation. Bromeliads are kind of interesting. Bromelian is a compound that is actually derived from pineapples, both the flesh of the pineapple, but in this case, also the top of the pineapple that they isolate this from, and potentially looking at inflammatory regulation associated with it, which is interesting. But it also is important to keep in mind what people are allergic to, because they may not realize that some of these things are derived from some of these natural ingredients. Sarcopenia, looking at muscle breakdown and dysfunction, as well, looking at those arginine amino acids, iron, magnesium, selenium, all those good things. And then beetroot juice is kind of self-explanatory. It comes from beets and all the compounds that potentially could be associated with that. And then also looking at pollen-based herbal extract and vitamin D, again, though, being careful with allergies that people can have. So I'm excited to see, because this group seems to be very good about, kind of applying a rigorous measuring stick to these supplements and wanting to show that they actually benefit people by using randomized control trials. The other one that's interesting is N-acetylcysteine, or NAC. I'm very familiar with this compound because back, when I was a fellow, we were looking at using this for patients with lung scarring diseases, interstitial lung disease. This is a natural antioxidant, anti-inflammatory. It has a sulfur moiety to it, so it can have a bad taste. And so you can get this from GNC or wherever. And I used to recommend people put it with Coca-Cola Classic, not diet, but the regular Coke, because it would help to hide the really bad taste. And then typically what you'll see is about 600 milligrams of NAC done daily. There is a Yale protocol that was published. I have the reference at the end, combined with a prescription medicine, guanfacine. And guanfacine is associated with assistance in the prefrontal cortex. It was actually originally FDA cleared for ADHD. And then starting with 1 milligram and then increasing to 2 milligrams after 1 month, and taken at bedtime. And this protocol is to help with brain fog symptoms. They reported their clinical experience of being 8 out of 12 patients responded. The guanfacine needs to be a prescription, and some patients did stop that due to hypotension and dizziness. The challenging part of this is that they have yet to, and they acknowledge that this needs to be in a placebo-controlled trial. The other thing is that the person that's a co-author on this paper, their particular lab is the one that discovered the scene. So there may be some financial conflict of interest, which is also something to keep in mind. And then acetylcarnitine is another one that's interesting. This is actually just showing that this pathway is relevant to your mitochondria, your powerhouse of the cell. And it's the shortest metabolite of a class of fatty acid metabolites called the acetylcarnitines. And it's one of the most abundant blood metabolites in humans. It can be used as a dietary supplement. And it's been used actually in some other good trials, which major depressive disorder, chronic fatigue syndrome, and other neuropsychiatric issues. And then there was a meta-analysis done of this where they looked at 12 randomized control trials, and they showed a significant decrease in depression severity in as a therapy compared to placebo or no intervention. And the incidence of adverse effects with it was comparable to that of placebo, which seems relatively safe, and lower than that with antidepressants, in line with a prior meta-analysis. So if from a cost benefit sort of harm perspective, this seems relatively safe. And, it's been interesting for that. And then a recent study looking at patients with long COVID syndrome reported a decrease in fatigue with an increase in subjective energy levels after taking 150 milligrams for 2 weeks. This again was not placebo controlled. It was a pilot observational study. So I anticipate that people will be more interested in that one as well, just given the safety profile seems to be pretty good. And there are, just in general, though, there are a lot of supplements on the market, and a lot of things are being looked at to treat the symptoms that a lot of patients struggle with long COVID. There are a lot of interesting candidates, and your patients may already be taking them or trying them. So it's important to chat with people and engaged with shared decision making about, potential risks and benefits. And then also knowing about them is key for looking for potential side effects. And these are some of my references. This is a pretty extensive one from that Italian group. This one was the neuropsychiatric one, looking at this use in long COVID. And this is the NAC plus guanfacine one that's out of the Yale group. Their experience with that was the 12 patients that they looked at. And then again, UpToDate has a really good chart for the recommended daily allowance for different vitamins and supplements, and beyond the normal RDA, probably be looking to monitor levels to worry about safety. I will open it up for questions or comments.
Thank you for that, Dr. Brown. That was really informative. There has been a little bit of chatter in the chat box. I want to do a couple of different things here. I want to start with a comment from Meredith, who mentioned that vitamin B6 toxicity, which can lead to neuropathy in this particular patient group, to be really careful with using over-the-counter supplements like liquid IV, which can be helpful for those with orthostatic intolerance, and we often, prescribe that fairly regularly. But to be careful, because those packets have over 100% of the recommended daily intake and can lead to toxicity levels. And then Jen, I just want to call on you. Jennifer Bell mentioned that she has seen this in some of her patients, and she was looking up an article. I'm not sure if you found that, Jen.
I think I found the article, but it's really hefty and long, so I'm not sure I can find this, but I will. When I saw that this was happening, I was having some people come back with B6 levels very, very high.
Yep.
And when you look at the literature to sort of start and just kind of looking through, they say, you have to, it's really only from, supplements, but they have to be like over 200 milligrams a day of ingestion. And my patients were maybe getting 6 to 12 milligrams a day or something like that. So it's much smaller than was expected. But I spent some time, this was a while ago, so that's why I'm having trouble making sure I have the right article. I spent some time looking into this at one point and found this obscure article somewhere where it talked about that B6 is stored in the muscle to help with protein synthesis. And they made the hypothesis that if you have people who are not moving very much, that they maybe could have B6 toxicities even at lower supplement doses. And I can't find that phrase. I think I have the right article, but I'm not sure. But so I don't know. I had people really stop all the B6 that they could, including liquid IV. Their levels dropped back into the normal range. So I think this population has a tendency to be more at risk for B6 toxicity, even if they're not taking anywhere near the supplemental doses. I'll see if I can we'll see if I can find it before the end of the meeting.
Thanks for
Jen.
bringing that up. It's sneaky. The other thing is also labeling too, right? We're relying on companies to be accurate. There are a number of I should have thrown melatonin in this one too, but there was a couple of studies that have looked at like pulling things off the shelf and looking at what they were labeled to be and then actually checking them, and they vary wildly. So again, you're hoping that the company's accurately measuring and labeling, which is again the Wild West. And it was somebody in the chat, like, how how not well regulated they are in the US. I'm like, unfortunately, there was some political aspect because this is a huge moneymaker, frankly. And so it's really on us a lot of the times to show that there was injury. But the other thing is these studies, again, is things change, or specific populations like COVID patients that may be more at risk for something. The only way we're going to find this out is to measure it. So there's a hand up.
Anne?
Yeah, sorry. I just wanted to mention a very interesting discussion. And in Canada, we had a presentation where there was a lot of patients, and a very enthusiastic researcher mentioned taurine, since they had interesting correlation results in their finding and they want to pursue it. But the researcher was very enthusiastic. And we saw immediately on the Facebook groups that people rushed to taurine. So I just wanted to mention that, and also stress not only how important it is for us to understand, but also for patients to understand, not only because of money, but because of uncertainty around it. And that we as scientists, we need to be very careful how we convey the message, which is not a problem here at all.
I agree with you 100%. The other thing is that I feel like there are a lot of people in the general public will have, well, if some is better, more is better, or some is good, more is better. And so, if some vitamin C is good, then I should should take max doses, or, because we've had patients show up in clinic that have been toxic on all these, and we're like, you're hurting yourself, and so that's like a lot of that is that shared decision making and helping them understand just because this is over the counter doesn't mean it's safe. And then there's another comment in here about, vitamin D levels. Yeah. I mean, the US task force, a lot of this is looking for vitamin D deficiency for bone health, but we know that it's important for a lot of other things. But the other thing is why people are so low potentially is also the form of vitamin D that they're getting in their food supplementation. D2 isn't as well absorbed. And so again, just asking people, sometimes keeping dietary logs and those sort of things, or like, if you're like me as a vegetarian, like I'm, there are just going to be certain things I'm maybe more prone to being deficient at. But we're seeing people do like FODMAP diets and histamine diets and all sorts of versions of this. It's important for folks to potentially work with a dietitian or be measuring levels or both, just to make sure you don't, I've seen a patient with scurvy. You're like, never thought I'd have to say that out loud here, and yeah. Daphne?
I work with
There
a
we go.
real nutritionist for Mast Cell because I just could not get a handle on it. And I still haven't gotten a real handle on it. But one thing she did tell me about probiotics, and this is just FYI, y'all can decide, you're the scientist, is that some probiotics have high histamine. And so you have to watch which ones you take, because if you take the one that's high histamine, it's going to give you the red face that's now popping up on my cheeks. So just to tell you that. And she was real funny because I wanted to take this one that comes from England that I really liked. She looked at all the ingredients and she said, no, it's got, histamine. So
I think you make an excellent point on paying attention. And this is the other thing too. So people are taking multiple supplements. If you make lots of changes, you don't know which things are what. So it's being very meticulous about your sort of detective work and also, looking up ingredients and things like that. Sometimes it might make sense to actually get a supplement from another country that may regulate it better. So.
I want to
Um,
call attention to a question that David put in the chat.
Mhm.
And David, I don't want to speak for you, but I like this question around postulating if zinc supplementation would help with dysgeusia when taking Paxlovid. If so, can Paxlovid deplete zinc levels, hence increase incidence of rebound COVID? Any thoughts on that?
That's an excellent question. In my review of Paxlovid, I've not seen that per se. The thing I get from a lot of my patients when I give them Paxlovid is that it tastes like metallic. But I'd have to specifically cross-reference that. But it could be interesting, and they may or may not have looked at that with their basic research. I'm not sure.
It's more of like a study idea, supposedly. Because it was more of like rhetorical. I don't expect it because I didn't see
Right.
anything like that. But since you mentioned, just put the two and two together and said, is this possible?
100%. I mean, that's what I love these conversations for. It's like fun ideas. And then microbiome stuff of probiotics, challenging. The hard part about probiotics again is it's not regulated. Like Align is one of the commercial ones that I know that has more clinical studies, but again, you're relying on the company and you're relying on manufacturing processes to be consistent for live organisms. And that can be tricky, and you have to find the sweet spot of which ones to give and in which cocktail. So I think a lot of that again comes down to I don't think we know enough yet to say you need strains X, Y, and Z in this combination and this concentration. But
I'd be curious, Jen and Dr. Bateman and Dr. Brown, what other supplements are you seeing a lot of these long COVID and ME/CFS patients taking? Because I know that there are quite a few things out there that folks are, they're just trying to get better. But I'm curious what else you've seen and if you have any recommendations.
They're all over the map. I've seen patients, I keep waiting for one to surface multiple times to see, but to see if there's any consistency. And this is among ones that my patients choose. I was just looking up here. I've been trying to keep a sort of a running list of ones that people have said they felt have made a difference. One that came up, I've only had one patient take it, is poly-MBA, which I think is used with cancer patients. It's very expensive, but she swears it has made a huge difference for her. But I don't recommend it to anybody at this point because I don't know enough about it. But I would say I have a couple of patients who've gone on the guanfacine NAC combination with positive results, but I've also had a few that I've tried on it and they haven't been able to tolerate it from a blood pressure standpoint. I'm just sort of looking to see if I can find my little cheat sheet here. I can't think of anything that really stands out that I would recommend at this point, other than like the oxaloacetate that we've been looking at. NAC, I agree. Treating deficiencies as we find them, that kind of thing. So
NAC, like I've not heard anything bad, and I had quite a few years of experience with it, other than it just tastes bad. Which can be, it could be one of those things that people try for a little bit. If it tastes like terrible, then I don't take it. But Chandler also brought up there's so much on the internet, but like a Substack looking, pharmacists who sent out surveys regarding supplementation. I also try to keep track in the Facebook group online for the Utah Facebook group, just to see if people are commenting about specific ones. and also in our clinic. Fish oil is interesting too. I keep track of people's lipids. There actually can be a paradoxical increase in LDL with certain fish oils as well, and the fish burps. People don't like the fish burps. Um, so again, it really depends on why people are taking certain things as well, and their individual cardiovascular risk factors. And again, the B6 can be tricky, and people taking super supplementation of, or just not even realizing it's in certain foods and things too. It's sneaky. The other thing is manufacturing process. I recently, speaking of foods, the labeling for allergies changed. So a lot of manufacturers are now using sesame flour and other sesame products. So I've had a patient in the ICU because she has severe sesame oil or sesame allergy, and suddenly things are showing up, for other reasons, and it's not well labeled. So FYI, that's out there. And again, I think just as Jennifer, because Shauna asks in here, do you recommend any of these to your patients? The ones I really go for are like the true vitamin deficiencies that I'm looking at. The other ones, and I like David's comment about dehydration, I can kill people. But, just again, kind of that shared decision making with people of what are their goals, what are the main driving symptoms. If it's fatigue, yes, we'll supplement all the stuff we should supplement. By the way, for depression, ferritin levels, they potentially up to 100 for some of those folks. So again, picking your battles, picking which things you want to look for, and not. Oh, that was
Yeah.
good. I'm glad you found.
I like a couple of the other comments in the chat, which mention other kind of neuroprotective type supplements. Dr. Hoppers wrote in the chat, rutin, I'm bad at these things. Luteolin, quercetin, I know that one, and palm oil. I've also heard some patients taking lysine if they have particular viral reactivation. I think all of these things, it's a matter of making sure that the mast cell's controlled, right? So they're not reacting then to a supplement that they may or may not realize that's the reaction they're having, or even the capsule that supplement is how it's being administered. There's one more question I want to ask here. Someone asked, I've seen videos of people promoting magnesium and ashwagandha together to help with symptoms. Have you seen patients asking about this combo?
I haven't seen that one. I don't know if anybody else is, but that's the thing about the internet is like it just takes one post or one TikTok or one whatever. Like that one has not been on the my radar. I don't know if it's been on other people's radars, but
I'm seeing some head shakes. Dr. Yeoman, I know that oxaloacetate has been a particular area of focus lately, especially in the long COVID world. What have you seen with that, and why might people be taking that?
Yeah, so oxaloacetate has been studied specifically to look at helping people with fatigue. And when you say fatigue, you have to clarify exactly what you mean. So I think it's more the heaviness in the muscles, the lack of, as we sort of use in geriatrics, the lack of get up and go, as it were, not necessarily a sleepiness or somnolence or brain fog per se. But in people, and this has been my clinical experience, there's certainly in the studies, it suggests that some people respond, some don't. In my experience, the people that respond to it are those who have relatively good medical control of some of their other comorbidities first, who are not in, dysautonomia and sympathetic overdrive and are not dealing with major mast cell activation. When those things are all active, I haven't seen oxaloacetate move the needle. When those things are not active, I would say a decent proportion of people do take oxaloacetate and feel that it helps with the overall energy available at the level of their muscle. Some people have talked about kind of getting a lactic acidosis feeling or a marathon running feeling in their muscles, that's often a good target group to sort of look at for this. And they will sometimes say, look, I don't get that feeling quite as easily or at all with basic everyday activities anymore now that I'm using oxaloacetate. All that being said, oxaloacetate is extremely expensive and hard to get for people. When I do have people started, I say, look, start with the highest dose, the dose that was studied, which is 1,000 milligrams with breakfast and lunch, and that is a lot of money. But start and establish whether the mechanism works or not. And when we've established that the mechanism works, then back off on the dose and see what the lowest effective dose that you can get away with or tolerate or afford is. So I've had people go from 1,000 twice a day, say, yeah, this is definitely helping. Then they'll go down to 500 with breakfast and lunch, and they'll say, well, it's not as good as 1,000, but it's 80% as good for 50% of the cost. That's my sweet spot. And we say, okay, and we just go with it there. So the other way around, I've seen people start with really low doses. Oh, I'm taking 100 milligrams. I don't feel anything. And it's like, well, does the mechanism work, or is it that you're using too little? I just kind of find that to be a waste of people's time. So before even starting it, you want to make sure that people can maybe follow it through on the cost perspective, or if there's something very specific coming up for which they need a little more energy or a little bit more of a leash, so to speak, if they have some kind of upcoming procedure or they need to go to their son's wedding or something like that, it might be a decent time to introduce something like oxaloacetate as well.
There's a comment in the chat, or a link, sorry, from Dr. Bateman looking at ashwagandha, which is an herbal supplement. It's primarily been used traditionally for Ayurvedic medicine in India. And that one actually has some decent research independently on sleep and heart rate variation as sort of a stress, like adaptogen. I'm using that very generic term, adaptogenic herb. That one seems to be okay. I guess I could have thrown in melatonin too, but I was trying to limit to where we looked at like long COVID specifically, not just generic, but I've seen tons of people use melatonin. The other question that was in here from Kelly Franklin was nattokinase. I didn't run into that in my literature search, but that being said, that was part of the reason why I showed how many like results you get when you type in COVID and supplements, is because it's a challenge to keep track of everything. So I'm curious if anyone's used that or knows much about it.
Jennifer, was that what you were going to speak to?
I'll answer that. I had one other thing I wanted to say. I have one patient who's on nattokinase and swear it's made a difference based off of WebMD, but I haven't done a deep dive into it. It's supposed to help with vascular health, lower risks of blood clots, but she feels that it's helping her quite a bit. But what I wanted to mention, I put a site in here, consumerlabs.com, which is I say fairly independent analysis supplements. The reason I say fairly is that the companies that have their product analyzed, they volunteer to have it analyzed. So they're not just pulling them off the shelf randomly, but if there's at least there used to be a $25 subscription yearly to get it, but it's pretty valuable. It really pulls apart different products in terms of determining whether their ingredients are what they say they are, and the quality of the fillers and everything else that they put in them. So that can be helpful, and I felt a worthwhile $25 to spend.
Thank you. This was a great discussion today. As we're wrapping, I just want to remind everyone that we have a special quarterly echo on April 18th. We only have 2 left for this particular series, and we will pick back up in the fall. But on April 18th, we will be joined by the Mayo Clinic and their post-COVID care team, where they will be talking about implementing care plans. So we hope to see you on April 18th, and then May 2nd will be our last session with Beth Polak. She's an MIT researcher and scientist. She'll be kind of pulling all of this together and talking about some of the lesser studied pathologies. So we hope to see you there.
Cool. Thanks for joining, everybody.